welcome everyone to another Menopause Talk by Let's Talk Menopause, which is a national nonprofit changing the conversation around menopause so women get the information they need in the healthcare they deserve. My name is Jessica Levin, and I am the Menopause Director. Before I introduce our incredible guest today, I just wanted to start by thanking Revel, our partner in these Menopause Talks. And I also want to thank Alloy and the Academy for Continued Healthcare Learning for supporting our Menopause Talks. I did want to do a quick medical note. These talks are intended for informational purposes only, so not as a substitute for professional medical advice, diagnosis, or treatment. So please see a menopause-informed provider for those purposes. And just a few housekeeping items. The chat will be turned off for you all during the menopause talk, but we will be sharing links and information in it. So if you have questions, please share them in the Q&As, and we will try to get to as many of them as possible because we know how important it is to answer your questions. At the end, we're going to have a brief survey, and we really hope that you can respond before you jump off so that we can continue being responsive to you and can continue to improve these talks based on your recommendations. So I now want to, before turning it over to our guests, I am thrilled to introduce them. And we have both Dr. Larkin and Streicher and Dr. Lisa Larkin. And Dr. Larkin and Streicher is a clinical professor of OBGYN at the Northwestern School of Medicine. And she is also the founding medical director of the Northwestern Medical Center for Sexual Medicine and Menopause. She's a certified North American Menopause Society practitioner, and she's written multiple scientific papers and books with amazing sounding names that hopefully she will bring up at some point in this menopause talk. Dr. Lisa Larkin, who is educated at Yale and University of Chicago, is a women's health internist in Cincinnati, Ohio. And she is a national expert on midlife health, including menopause management, sexual medicine, breast cancer, assessment and prevention, and migraines. And she is the founder and CEO of Miss Medicine and Ms. MedEd, which she uses to continue her consumer and clinician education. She is also the president-elect of the NAMS Board of Trustees, which you will likely hear more about also. So we are thrilled to have both of you here today, and we now are turning it over to you. And thank you so much.
Thank you. We're excited.
Well, thank you. Yes, we're excited to do this talk because Dr. Larkin and I spent a lot of time talking about this to other medical professionals and to women. So this is an exciting thing for us to be able to put this out there and have this open discussion. So we're going to do a couple of cases as a jumping point for our discussion. So let's bring up the first case. All right. So this is SG. She's a 52-year-old woman. She stopped getting her periods almost a year ago, and she came in saying that she had two major issues. One are these hot flashes, which are going on all day, but particularly all night, so she can't get a decent night's sleep. And she did try some black cohosh, and that seemed to work for a little bit, but then after a while, it just wasn't cutting it. The other issue she had is that her sex life was basically gone. You know, she did not have pain with intercourse like a lot of her friends, but she basically had absolutely no desire. And she had found that having an orgasm was next to impossible, even though it had never been an issue before. So one of her best friends was using a pellet with estrogen and testosterone and felt great. And she went to her own doctor and said, hey, I want one of those pellets. And she was told, not such a good idea. I really don't think you should. So she's thinking about getting one anyway and wanted to know what our advice. So that's what we're going to start with. And I am going to get Dr. Larkin to weigh in on this right now, because this is a story we have heard too many times to count. The women that come in and they talk about their pellets and how wonderful they feel. So why don't you start by telling everyone, Dr. Larkin, why do people feel so amazing when they are using pellets?
Even before I get to that, I just want to say that what we know is the majority of women who are having symptoms related to menopause aren't getting great care. And if you are a woman listening to this and are having symptoms, please make sure you're talking to a provider that's familiar with all of the options related to menopause and has some experience in this space. But the patient you describe is someone that I see day in and day out. And first and foremost, I want to say that the language between pellets and bioidentical gets very confusing, right? So these pellets are marketed to be bioidentical. But what I want to tell you is there are FDA-approved bioidentical hormone options that I prescribe day in and day out, and you can get bioidentical hormones without having to do a pellet. But the pellet business in my Cincinnati community is huge. It's growing. We know the numbers across the United States. This is $1 billion business. And what's really happening? Well, I like to say that the first time a woman gets a pellet, the reason they market this for the company directly because they feel great when they get that first pellet. And the reason for that is supraphysiologic dosing, which means they're giving testosterone at levels that are way above the normal female range. And testosterone has real effects on women. It is converted into estrogen and helps hot flashes, but it is the hormone of desire. And so women often feel very energized with that first pellet. Their libido is better, their hot flashes are better. But when I typically see patients is about at 2 years after they've been getting these pellets, and all of a sudden the side effects of the supraphysiologic dosing are now starting to become really apparent. And this is a problem. You can get bioidentical hormones. I prescribe hormones day in and day out with FDA approved products. And pellets are really not a safer or a better way to give hormones. And Lauren, I don't know if you want to add.
No, and not only are they not safer, but let's talk about how they're actually less safe than commercially available compounded hormones, because we are seeing people that are getting into trouble. But beyond that, in the literature, we have very good evidence that women that use pellets are at higher risk for even some kinds of cancer. So talk a little bit about why it's dangerous, because we see these women, as you said, all the time, and they're like, what do you mean I shouldn't get the pellet? I feel great. Why would you take this away from me? So what are the specific dangers that women need to know about?
Right. So again, these are often the levels of hormones that you're getting are way above what we consider to be normal and in range. And so, they are marketed as being safer because they're bioidentical, and that couldn't be further from the truth, right? So these are part of the problem with compounding is you can never be sure exactly what you're getting is exactly what you think you're getting, right? There's very loose regulation of these compounded products, but in general, they're much higher doses. And as I said, women will often come in to see me and say, I don't want to take the hormones that you prescribe because I'm afraid of breast cancer. But then they hear from the pellet people that, the pellets are safer and that are not associated with breast cancer, which again, couldn't be further from the truth. And both the supraphysiologic dosing of testosterone as well as estrogen has all kinds of negative effects. I use the analogy in the transgender world. In trans men, we are using testosterone in male dosing to get the male effects. And I can tell you that having a transgender stepson and seeing where we dose those levels of testosterone compared to what I'm seeing in practice, the doses we're using in him are much lower than that I'm seeing with women who are getting these pellets. So these supraphysiologic dosing has male effects, but also again, the higher levels of conversion into estrogen can cause risk for breast cancer. And again, the marketing that they're safer is just simply not true.
I want to back up for a second because I had a comment from Nancy who never heard of pellets. And I think maybe we need to describe a little bit more what they are before we move forward. And basically, pellets are a form of postmenopause hormone therapy that are generally administered by physicians, most of whom, quite frankly, are not menopause experts. In fact, a lot of them aren't even internists or gynecologists, and certainly not endocrinologists. A lot of them are inexplicably emergency room doctors. And basically, they have very, very high doses of estrogen and testosterone. testosterone. And we're going to circle back to the testosterone part a little bit later about, do you even need to supplement your testosterone? But so Nancy, that's the issue with the pellets, is a lot of women are going to doctors who portray themselves as being menopause experts and getting what I call the chip in the hip, which they say that, oh, we're going to measure your levels, and they charge you for all this, these blood tests and everything, and saliva tests to look at your hormones, to say that they're going to make it specifically for you. And they're basically putting the same pellet in everybody. The whole thing's a scam. But the other thing, after Dr. Larkin mentioned, all these risks, there's one other risk that's very, very important, and that we've seen a significant increase specifically in uterine cancer. And this has been well documented, that women who use these pellets, not in the short term, so if you've only been using it for 6 months or something, don't get all freaked out. It's for the people that are using it longer term. And it's because they're using these super physiologic, these super high doses of estrogen and testosterone, which is stimulating the lining of the uterus. And you can sometimes get precancerous and cancerous cells. So the one question I will throw out there, if you are using a pellet, other than, stop, is if you are having any abnormal bleeding, please see a clinician to see what's going on, because the majority of the people who put these pellets in, they're not gynecologists. If you say I'm bleeding, they'll say, go see a gynecologist. Are you kidding? So it's very important that you just make sure that you're not getting something bad like the hair growth, the acne, the enlargement of the clitoris. I mean, we see all that stuff because of these super high doses. So, all right. So let's move away from pellets for a second, because I think we made our point with that. And Dr. Larkin, let's talk about libido a little bit, because the whole reason a lot of people are getting pellets is because they have no libido, the number one sexual complaint in postmenopause women. So let's back up and not talk about testosterone for a second, but let's just talk about the woman who has no libido and she chooses to take estrogen therapy. Is that going to help her libido?
So that's not a straightforward question, which
Of course not.
With, menopause, by definition, the ovaries are no longer producing estrogen, estradiol in the levels that you were when you're having normal cycles. And there's a lot of consequences of that. One of them being sexual dysfunction related to the tissue in the vagina changing as a result of not having estrogen around. So many women, as they transition and get beyond that final menstrual period, will have vulvovaginal irritation, discomfort, dryness, and sex suddenly becomes painful. And, it's like anything. You don't want to do something that hurts. And so having repeated episodes of painful intercourse, again, can negatively impact libido. So when I'm evaluating a patient who's postmenopausal, who is complaining of low desire, the first thing that I really want to address is make sure that pain and dryness and what we call genitourinary syndrome of menopause is not really the first problem. And often it is the first problem, which is related to estrogen. And I will work to address that first and make sure that they're having comfortable, pain-free sex, and then circle back to other issues that impact desire. So I don't know.
But Dr. Larkin, it's okay. I 100% agree. If you have sandpaper sex, if your vagina is dry, well, of course you're not going to want to have sex. But in our patient that we presented in this case, she actually said she wasn't having any pain with sex. But the other thing she was having, of course, was, she wasn't sleeping at all, right? So could you talk about the impact of estrogen and maybe helping her libido if she can actually get a decent night's sleep?
So, all of those things play into the complexity of desire for women. And certainly chronic sleep disruption related to hot flashes contributes to desire, loss of desire. So absolutely, in that way, starting with thinking about hormone replacement therapy or hormone therapy at menopause, when it's really estrogen that we're talking about, if you want to wait to talk about testosterone, is really the first right thing to address all of those issues.
Yeah, absolutely. And so in answer to Julie's question, the best solution for sex drive, we don't have one best solution. It really is very individual, but certainly to make sure that sex is not painful is number one. Number two is that you are getting a decent night's sleep, which may have to do with getting rid of the hot flashes. We're going to talk about that a little bit more later. But then I think to your point is, what's the role of testosterone in all this? Because testosterone is not a male hormone, it's a human hormone. And women, make testosterone just like the guys do. And interestingly, it doesn't actually plummet with menopause, but it does start to go down with age, which is inconveniently about the same time as menopause.
Right. So I talk to patients about that, and that's exactly right. So testosterone levels begin to decline in the mid to late 30s. What I typically see, though, is many women don't really have they're noticing that their libido is changing and declining a little bit, but it's really at menopause when now they're having all of these other symptoms in addition to the low desire where the wheels kind of fall off, right? So it's not that testosterone changes abruptly at menopause. It's already much lower than it was at the peak when women are in their 20s and 30s, but it doesn't change abruptly then. But it's the combination then of the loss of estrogen and the loss of testosterone, or the lower testosterone levels that really impact libido.
Yeah. And certainly you and I think are on the same page that there are times when we will supplement testosterone. It's not that we don't, we just won't do it in pellet form. We do it in a transdermal gel, which is, while it's not FDA approved, it's considered to be off label, but we certainly do have good data to show its safety. One of the things that's interesting, though, is that it's not the magic bullet. We know that if we give testosterone to women, we're looking at best about a 50% increase in their libido. And the reason for that is because libido is so multifactorial. You know, it's not just hormones, it's all the other things going on in your life. Not to mention, I tell some people they need HRT, which HT is hormone therapy and HRT is husband replacement therapy. So we also have to look at the relationship as well. So, you know,
Absolutely.
That's all part of it. We've got a couple minutes till we move on to the Q&A period. You want to talk a little bit about how you go about giving someone supplemental testosterone if you think it's going to benefit them?
So that's right. So the good news is in the last couple of years, our sexual medicine organizations have come out with really clear guidelines about how to use testosterone, even though, as you mentioned, there is not a formulation that is FDA approved specifically for women. What we know is that the dosing in women should be about 1/10 of the dosing in men. And so there's specific ways that we can use male products and decrease the dosing to apply the testosterone the way that men may do it in gel formulation to women at the time of menopause when they're having symptoms of low desire. And the reason we're using the dosing, and I'm very careful about the dosing, and I know that you are as well, is that we don't want to make women supra-physiologic. We don't want the dose to be too high. And so really and infrequently do I measure hormone levels, but where I will measure hormone levels is in women who I am using this male formulation at about 1/10 the dose to just check and make sure that I am not making them super physiologic, because the goal is to get women back to a range where we think that they were in their mid 30s, right? So we don't want to push them too high. We certainly don't want to push them into the male range like the pellets do, but we want to get them back into the normal female range.
Yeah. And, we don't routinely measure hormone levels. Like if someone hasn't had a period in 3 years and they're 55 years old, we don't get an estrogen level because we already know it's 0. It's not telling us something we don't already know. But testosterone is a little different because women make testosterone not only in the ovary, but also in the adrenal gland. So even if someone has had their ovaries removed, you still may have adequate testosterone. So we make no assumptions. And the reason we get the level is, interestingly, it's not as if testosterone levels that you make correlate with libido. Someone can have very low testosterone levels and a great libido, and someone else can have high testosterone levels and no libido. It just kind of tells us where you're starting from, so we can kind of figure out dosage wise what we're going to do. Let's get to a few questions for a few minutes here before we move on to the next case. And I want to address Sherry's question about painful intercourse, because we hear this all the time. I mean, Sherry, you're talking about your tubes and ovaries were removed and intercourse is so painful that you cry and it's excruciating, and you have a decent libido, and you have been told that you should not be using estrogen therapy. So number one is you should never have painful sex. Never, 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 never. And until you get this figured out, I would encourage you to have lots and lots and lots of sex, but no intercourse, because every single time you have intercourse, it's just going to make it worse. So if you have a great libido, excellent, make use of it, but you need to find an expert who's going to figure out what to do about your dry, painful vagina. And if in fact you really can't use a local vaginal estrogen, with your condition. You said you had an idiopathic angioedema, which I think is up for debate. But if that is in fact the case, there are things that are non-estrogen that you can use. So Dr. Larkin, you want to jump in and talk about some of that?
Absolutely. And again, this isn't, I don't know the specific medical circumstances for this patient, but I would really argue that it's almost no individual who can't use local vaginal estrogen, and that it really is, there really is no contraindication. The data is, and what women need to understand is, yes, I know that on the vaginal estrogen, it still has the same package warning as every other estrogen containing product does, which makes you terrified. But what you have to know is that the dosing is so dramatically different. So if we do the math and we're using standard low dose local vaginal estrogen therapy, 1 year of local vaginal estrogen therapy has about as much estrogen as a single birth control pill, right? And you get transient, maybe brief elevations initially with local vaginal estrogen in your bloodstream. It's completely different than using what we talk about menopausal hormone therapy, where we are giving it systemically and you are getting levels. But let's say that you are specifically not able to use estrogen. What I would tell you is there is lots of options out there, and really anyone that tells you, I always like to take care of painful sex because I tell someone I can always fix them, right? And I use it as, it's a project, and it may take 6 or 8 weeks. It may involve physical therapy. It may involve pelvic floor physical therapy. It may involve dilator therapy. It may require things that I'm asking you to do every day, but in general, we can get you back. And I have many patients who have been abstinent for 20 years and then in a new relationship, and I can get them to painful.
Absolutely. We always get really happy when someone comes in with this problem, because there's very few things in medicine that we can pretty much say 100% we can make this go away. And this is something that almost 100% we can make it go away. And just to close the loop on this. So I agree with Dr. Larkin, of course, that pretty much every woman can take a local vaginal estrogen, but if for whatever reason you either choose not to or have been advised not to, there's a DHEA suppository. DHEA is the building block for estrogen and testosterone. These are vaginal suppositories. And yes, you do have testosterone receptors in your vagina, which are also important when it comes to lubrication. And then someone had asked about the Mona Lisa laser, which is something I've actually been very involved in and have written quite a bit about. And I have a very large program here at Northwestern. And in the right hands, it's got to be in the right hands, someone who's done a lot of this, and most important, does an appropriate evaluation to make sure that's why you're having pain. Mona Lisa actually can work very well in terms of alleviating the dryness, the lack of lubrication, and the pain with sex, very often in conjunction with other treatments that Dr. Larkin mentioned, like dilators and pelvic floor physical therapy. This sounds more complicated than it is. This is a fixable problem. This is when you mentioned my book, Slip Sliding Away, Turning Back the Clock on Your Vagina, basically goes through step by step all of your options, both hormonal and non-hormonal, to make sure that you have appropriate vaginal lubrication, elasticity, and pain-free sex. And the other thing I want to mention also is for women who are taking systemic estrogen, for a lot of those women that will help the vaginal issues, but not for everybody. And about 15 to 20% of women, they're still going to have problems. And I think the last thing that's so important to mention about the vaginal stuff is it's not just about sex. It's not just about pain. It's not just about the dryness, but it's also about your bladder. Because Dr. Larkin, you'd mentioned genital urinary syndrome of menopause. Talk for a minute about the impact lack of estrogen has just on bladder symptoms.
Right. So again, that's why we in 2014 changed the name, right? Because it used to be called vulvovaginal atrophy, but really we know it's much more broad than that, right? And that recurrent urinary tract infections and bladder symptoms of urgency, frequency, we call it dysuria, are really common and also treated with local vaginal estrogen therapy. So again, if you're having recurrent urinary tract infections, which again often become a problem after menopause in women who remain sexually active, because for lots of reasons, change in the vaginal pH, change in the vaginal microbiome, that the first therapy for recurrent urinary tract infections in a postmenopausal woman is local vaginal estrogen therapy. And again, really, I would tell you that there's no contraindication to using local therapy.
Absolutely. A couple of quickies before we go on to the next one. Someone wanted to know about estering. Estering is one of the local vaginal estrogen options, of which a lot of people think it's just the cream. The cream is the most commonly used, but there's suppositories, there's tablets, there's the estering, which is a ring which goes in the vagina, and you remove it yourself and replace it every 3 months. These are all local vaginal estrogens. They all work well. They are all equally safe. They do have little nuances that you need to know. But in general, these are all good products.
I will just chime in that I have many patients using the e-string and are very happy with that, right? It makes it much easier. You put the ring in, it stays in for 90 days. You don't have to think about using the tablets or the creams twice a week. It's not messy, and it's often very, very effective. So I use the ring a lot.
Yeah, I'm with you on that. The only downside is sometimes with the ring or the tablet, it doesn't help the opening of the vagina as much, and that's called the vestibule. And I always say it doesn't matter how nice the room is if you can't get through the door. So sometimes we need to treat the vestibule, the opening of the vagina, with a cream separate from the ring or the tablet. Nancy wanted to know if testosterone, because we were talking about it earlier, do you get a pill, a patch, a gel, or what? The answer is a gel, a gel. All of the FDA trials for testosterone that did not make it to the market were by a patch, and that was safe and effective, but no one is manufacturing a patch right now. Pill is not a good idea. The way to go is with a gel, and I will caution you to not use your husband's testosterone gel. It is a higher dose than what we prescribe, and you don't want to use his shaver or his razor also. So stay away from your husband's testosterone gel and get your own. You are worth it. All right, let's go on to the next question, the next case, if you want to bring that up. Is that coming up? Yeah, there we go. All right. NF, she's 47 years old. She's having terrible hot flashes, but she has a family history of breast cancer. Her sister was 49 when she was diagnosed. She had a grandmother diagnosed at 62. So she is terrified about taking hormone therapy and wants to know what else she can do. So she really has two questions. One is, how likely is it that she's going to get breast cancer? And is there anything she can do to reduce her risk? And the other is, how does she get control of these hot flashes? And the only other piece of information in her general health history is, because of these hot flashes, she's not able to sleep. So she's having a few glasses of wine every night to get to sleep. But otherwise, she's pretty healthy. She's a little overweight. She's borderline diabetic, but she has no other major health issues. So Dr. Larkin, this is your area of expertise. So start off by talking about, what is this woman's actual risk of getting breast cancer?
Well, first and foremost, I will set the stage that this is a very typical patient that shows up in a primary care physician's office, an internist, and they are absolutely told, because of that family history, that hormone therapy is not an option. And I want everyone on this call to hear that that's not the right approach, and that even in this patient with a family history of breast cancer, hormone therapy may be the best and the most reasonable option for her. And it's not black or white. And so again, if you hear that from your family physician, I would really encourage you to find a menopause specialist who really can talk to you about this. And the first thing I do in practice is really talk to a woman about her individual risk. So most of you may know the statistic, 1 in 8 women develop breast cancer, 12% lifetime risk. Those are common numbers that people know. The problem is that is population risk. So that doesn't, for an individual woman, tell you what your risk is. It might be lower than that 12% lifetime risk, or it might be substantially higher than that 12% risk. And what we know is that there are things that we have to take into consideration to calculate your individual risk. And there's models and ways to do this, because it's your individual risk related to your own genetics, which we have to take a family history. And so that family history of relatives is really important, but also to take into consideration your weight, when you had puberty, when you had menopause, what your breast density is, a multi-generational family history. And we can come up with a way that we can estimate your 5-year, your 10-year, and your lifetime risk of developing breast cancer. And what we know is that about 25% of women who show up in a gynecologist's office for their well women exam meet criteria. They should be referred for consultation to consider genetic testing, and we're missing most of those women. The other thing we know is that about 20 to 25% of women really are at elevated risk for breast cancer, meaning have a lifetime risk above 20%. And we're missing those women too. So first and foremost is really not just to depend on family history, because that's only one piece of the puzzle that influences risk. That really you should have a better understanding. You should talk to your physician about what your calculated lifetime risk of developing breast cancer is. And that's first and foremost. But again, what is driving the majority of your breast cancer risk is your own genetics, your own breast density, and then your own lifestyle. And so the other big thing that women don't recognize is that lifestyle matters when it comes to breast cancer. And we don't have to just be a sitting duck. I think most women think, I'm just going to get my mammogram every year, and I'm just waiting for that call back for someone to say, you have a mass, you need a biopsy, you have an abnormal mammogram, when really what we should be doing is really identifying women who are at high risk and then helping them understand what they can do to lower their risk. And what they should be doing is the same things that we talk about for cardiovascular disease risk reduction, diabetes risk reduction, right? So it's diet, mostly plant-based, it's reducing alcohol consumption. Really, there's no safe amount of alcohol for women when it comes to breast cancer. It's exercise. Exercise is really, really important, and maintaining ideal body weight. And these are things that have huge impact on breast cancer risk. In fact, the estimates are that in the United States, if we could get women to have a healthy lifestyle, that we would prevent about 33% of breast cancers every year. Prevent, not just detect them early. So first and foremost for this woman, she needs a formal breast cancer risk assessment so we understand her risk. And then we can talk about what her options are to treat her hot flashes.
Yeah. And in addition to make some of those lifestyle changes that you just talked about. But, I think, again, along to your point, when we talk about estrogen, and there's this basic feeling out there that estrogen increases your risk of breast cancer, just in the general population, not even someone who has a family history. And this is not controversial. What we know is that women that take estrogen alone actually have a decreased risk of breast cancer. A decreased risk. And that message is not getting out there to women, and it's also not getting out there to their doctors. And so many women are so afraid of taking estrogen when in fact it is going to decrease their risk of developing not only problems beyond the hot flashes, that they'll sleep better and bone health and vaginal health, but that it's actually going to decrease their risk of breast cancer. So I think, we need to change the message out there. Because that's really so important. The other thing also, Dr. Larkin, that I want you to talk about is, all right, you've mentioned that she probably should not be having half a bottle of wine every night before she goes to bed because it's bad for her breasts. Right. But let's talk about, is it really helping her sleep?
Right. No, alcohol is bad for sleep as well, which is it disrupts sleep architecture. And no, drinking alcohol every night is not good for anything, cancer risk or your sleep. So
it's good for a nice meal. I'm just saying.
Of course. And, again, right.
Yeah.
You and I know that, but
yeah.
Again, less is more.
Yeah. And I think when we think in terms of sleep, and we could do a whole hour on sleep, which we're not going to now, but when we look at why is it that peri and postmenopause women don't sleep, and the hot flashes are certainly one piece of it, the wine is not helping, but also there's so many other things like obstructive sleep apnea, which increases in menopause, by the way, because the structure in the back of your throat actually changes as a result of lack of estrogen, and also restless leg syndrome. So sleep is critically important for everything that we talk about, libido and just, cognitive function and just quality of life. So that the addressing sleep is so important.
So let's go back and just talk about hot flash options
let's talk about hot flash options. So when we talk about estrogen, which obviously right now is our go-to, is the gold standard in terms of being the safest and the most effective. But we did want to talk a little bit about if for whatever reason someone chooses not to use estrogen, or if someone has a breast cancer diagnosis and truly can't use estrogen, what are her options? So Dr. Larkin, take it from there.
Right. Well, there's lots of what we call non-hormonal options for hot flashes, and there's new ones coming up the pipeline. And I will talk about those, but I want to go back and just again re-emphasize that hormone therapy in this patient is likely to be the most effective option for her, and it will treat all of the symptoms that she's having across the board. And really, again, in a newly menopausal woman, the data is really clear about cardiovascular risk reduction, diabetes reduction, mortality benefit, right? Bone health, sexual health, cognitive function, I mean, sleep. We've heard all of these things, right? So again, family history alone is not the reason not to be a candidate for hormone therapy, even if that's what your primary care provider says. So find a menopause expert because it may be completely appropriate. The other point I just want to make is now Dr. Streicher mentioned about the reduction in breast cancer and estrogen only. That comes from the Women's Health Initiative, and that was with a specific type of estrogen called Premarin. But even if we look at worst case scenario from that study where there was and it was thrown all over the media, a 25% increase in breast cancer risk in the estrogen and progestin arm when they were using Prempro, I want everyone to hear that when we look at risk factors, all different kinds of risk factors for breast cancer, that the alcohol in this patient is at least 2 drinks a day is at least as risky as the hormone therapy. We have to put it all in perspective. And if we want to talk about what the bigger risks are, it's increased breast density, right? So again, for the women out there, if you have extremely dense breasts, that's the other reason, not just family history, to make sure you have your risk actually calculated and someone's talking to you about your breast cancer risk because it may be elevated. Okay, we switch to hormones or non-hormones. So as
non-hormones.
Right. So there's lots of things that we use out there. Many of them are the antidepressants, so the SSRIs and the SNRIs, so things that women are, Lexapro, citalopram, escitalopram, venlafaxine or Effexor are ones that we commonly use, paroxetine. There's several. Now, what some of the problems with using those medications are that, again, you mentioned that we talked about, women at midlife having low desire and sexual dysfunction. And a lot of times these medications just add to the sexual dysfunction. And so although they help the hot flashes some, not nearly as much as hormone therapy, they have other side effects related to them. So again, certainly try those. If sleep disruption is the primary problem, I often use gabapentin, which also has been shown to be beneficial in treating hot flashes. The less commonly used, because it's not been talked about for as many years, is oxybutynin. And so oxybutynin is a medication that's used for overactive bladder. It is effective for hot flashes. There are published trials to support that. And it is something that, again, it's not a hormone. Now, there's a little bit of concern about that related to long-term use and cognitive issues. And so again, none of these drugs are perfect, but certainly available. Now, the good news is there's been tremendous research in the space, and we have a much better understanding of what is a hot flash and where the problem is. And we now understand that it's not just about estrogen, right? Because what's interesting, if you think about it, is all women go through menopause, but not all women have hot flashes, right? It's about 70 to 75, 80%, but not all women have hot flashes. So it can't just be related to estrogen, right? So what we now understand is that there's a place in the brain called the hypothalamus, and that there's a pathway that we've now identified, which has led to the development of really targeted therapy, something that we're calling these NK3 inhibitors. And although there's nothing FDA approved yet, it's likely that one of them will be approved in the early part of 2023. And in looking at the data at this, it looks like this is they're effective with low side effect profiles. And honestly, there's some sleep data with them as well. And so I'm excited about this option, particularly I do a lot of breast cancer survivorship in my practice for women, and I'm a breast cancer survivor myself. And I say I'll be the first person to try one of these medications because I still have very disabling hot flashes and can't take estrogen, but it's coming. And I'm excited about it coming again, but not for all women, right? Like there's hormone therapy still going to be best for the majority of women.
And as Dr. Larkin said, the name of the drug, the chemical name is fezolinetant. I don't think they have a trade name yet, so I don't know how it's going to come out, but we are being told that we might see it as early as March. And this is an oral pill that's taken every day. So we're excited about that and about a lot of other things. The last thing I want to say about hot flashes before we move on a little bit is a lot of people think that hot flashes are harmless, that you should just tough it out. And there's two problems with that. One is they last longer than you think, an average to 7 to 10 years. So it's not like it's just going to be a few years out of your life. And the second is that there is a very, very high association with hot flashes and cardiovascular disease and other serious medical problems because of the elevation in cortisol and inflammatory response. So while we don't say that you should take this to prevent heart disease, we can say that if you're having hot flashes, if you treat your hot flashes, then you will hopefully lose that association with cardiovascular disease. So there's a whole thing about that. I see there's a lot of questions that come in. I promise you we are going to get to those questions. But before we get to the questions, I just want to touch on one other little topic which keeps coming up, and that is orgasm, because we know that postmenopause women have a lot of trouble having orgasms, and they just kind of give up, or they think this is just something that has to happen, and it does not. There are a lot of things that can be done for the reason why it happens. The general reason is that you have to have healthy nerve endings in your clitoris in order to have orgasms. And you might have seen the news that came across a lot of our social feeds in the last week about, instead of the measly 8,000 nerve endings in the clitoris, there's a new scientific study that shows that there's more than 10,000. And while most people were like really happy about that, my take was very different. I actually did an Instagram video on it yesterday that, these teeny, tiny little nerve endings are not great for postmenopause women, because the smaller the nerve ending, the greater the chance that it's not going to be as sensitive. We want sensitive. So more is not better. We want more sensitive. So I see a lot of women who have orgasm problems. And in fact, that is my next book, which is putting the O back in Mojo, A Guide to Postmenopause Orgasm, because there's so many solutions. I literally had to write a book. And please sign up for my newsletter, which is in the chat, so you'll know when that book is coming out. But the bottom line is that there are a lot of things you can do to increase the blood supply to your clitoris, that you can increase the blood flow that goes to these little nerve endings to make them more sensitive. And your vibrator is your friend, because it turns out that the nerves that are the ones that are going to hang out the longest and work the best are the ones that respond to vibration. So if the only thing that vibrates is your cell phone, it's time to go shopping, because you really do need a vibrator to help in terms of having an orgasm. A couple of questions on that topic that I'm going to take right now. Lisa, I'll let you take this one because I know we have the same answer. Talk about the O shot.
Oh, no, I'm going to let you talk about that. So go ahead, Lauren. No,
you want me to? Okay. The O shot is basically a procedure that someone takes plasma and injects it into the area right around the clitoris with the idea that this is going to help your orgasms. I will tell you that there is no data published that shows this to be the case. There's a huge placebo effect. There's a lot of people, like we were talking about compounded hormones. It's, very often the same people that are doing O shots. This is not the answer. We don't know the safety, the long-term safety. We don't think that it really works other than placebo. And we have so many other things that do work. So I would be safe in saying I think that neither one of us is a fan of the O shot.
I think that's right, which is, these are cash procedures that people are doing, and it's often in the same setting as these pellet hormone centers, and it's just consumer beware, right? It's women are desperate for solutions, and again, you have to be careful of who you're going for to get the solution, because women be sold a lot of things that have no data, don't work, and potentially can be dangerous.
And, I think that's our bottom line message is always, if someone isn't giving you a solution, it doesn't mean that there's not a solution. You just need to find an expert who can help you. And I know that's easier said than done, particularly if you live in a small town. But,
and I'll just say one more thing about the orgasm, which is I agree, of course, 100% with you that particularly as women age, a vibrator becomes very, very important. But having the tissue sensitized with hormones is important as well too. So part of the regimen is often topical estrogen cream, sometimes
directly to the clitoris. Ladies, do not just put that estrogen in your vagina. Put it on your clitoris, put it around the urethra, your vagina and your vulva love estrogen. So yes, absolutely. And estrogen is also a vasodilator. It increases blood flow to the clitoris. All right, what I'm going to do now in the time we have, there's a lot of questions here. So we're going to go through them super fast so we can get to as many questions as possible, starting with Nancy, who was told by her pelvic floor physical therapist that her pelvic floor was 2 weeks to have an orgasm. And she gave you annoying exercise using a pelvic wand. Well, my response to that is your pelvic floor physical therapist is kind of right, but not entirely right. You do need a strong pelvic floor that not only can contract, but can relax in order to feel that orgasm. But if your clitoral nerves are not responding, you can do pelvic floor PT until the cows come home and use that wand, forever and ever, and you're not going to get anywhere. So we really need to see what's going on in terms of the ability for your clitoris to feel sensation and to be sensitive. And, so many of the things that can be done. I do have a podcast on this, by the way. My podcast is called the Menopause Podcast. And I have one episode that's called Post-Menopause Orgasm, Everybody Come. And that one will go through some of the specifics in terms of what you can do to supplement what your pelvic floor physical therapist has told you. So
I would just jump in and say pelvic floor fit strengthening, if you have a weak pelvic floor, is a part of improving orgasmic function. And
it's a part of it. It's just not the whole story.
Multifactorial, like we've been talking about, multiple things. Everything has to work.
Yeah. Lisa, I'm going to let you take this one. Dense breasts, no history of breast cancer, but my doc doesn't seem worried about my density. Should I be pushing for something else, an ultrasound or another doctor?
Well, I'm not going to suggest you get another doctor, but what I would tell you is, yes, more women are looking at their mammogram and understanding the terms in there about breast density. And there's 4 general categories of density that you'll see on your mammogram. It's replaced by fat, scattered, heterogeneously dense, or extremely dense. And really what you want to know is if you have extremely dense breasts. So heterogeneously dense breasts increases breast cancer risk a little bit, but it's really the women who have extremely dense breasts where it's at least double your risk of breast cancer, right? So instead of having that 12% lifetime risk, many women with extremely dense breasts hit that threshold of having an over 20% lifetime risk. And in those women, yes, you should be getting a second modality for looking at your breasts, right? So part of the problem, so what is density? It's you have more glandular tissue than fat. What I tell my patients is the place where you want to have a lot of fat is in your breasts, but you don't get to pick that, right? So this is something that's predetermined. You can't control how fatty or how dense your breasts are. But with the increased glandular tissue, it makes on mammogram the whole breast look white. So yes, small tumors hide in women who have extremely dense breasts, but we also know that there's something different, unique about women who have dense breasts in terms of the local metabolism of hormones. We don't completely understand it. That puts you at higher risk. So if you have a calculated risk above 20%, you should be getting a mammogram every year and a second imaging modality, which means either breast MRI, whole breast ultrasound, molecular breast imaging, depending on where you are. In my city in Cincinnati, we only have breast MRI as a second option. But yes, so first and foremost, find out if you have extremely dense breasts or heterogeneously dense breasts. If you have extremely dense breasts, have your risk calculated. And if it's above 20%, you need 2 imaging every year.
All right, this next question is going to be a 1-sentence answer. It might even be 1 word. Thermography instead of mammography. Okay, 1 word. No, for those of you who are listening and not looking. No. Okay, I think we're clear on that one. This is from Erica, 47 years old. Is that, if someone's having symptoms, is that full menopause or perimenopause? Excellent question, Erica. The answer is either. A lot of, while 51 is the average age for someone to enter menopause, full postmenopause. It can happen anytime after 40. Anytime after 45 is actually considered to be completely normal. So some women at 47, their ovaries are done, their estrogen tank is on empty, and they are never going to make estrogen again. And other women at 47 are still pumping out estrogen, but it's going up and down, and she may be in perimenopause. And the second part of Erica's question about if she's on birth control pills, can that help? And the answer is absolutely. We use birth control pills, which should be called hormone pills, to help even out those perimenopausal hormone fluctuations. So, but that's a very common thing. A lot of people, they think they're too young for menopause, and they are not.
By definition, menopause is no menstrual bleeding for 12 months. You don't have to have a blood test. If you're on continuous oral contraceptives and you're not bleeding from that, you don't really know, right? So typically our approach is we leave women on oral contraceptives to somewhere around 50, 51, 52, and then we stop them and assess if they're in menopausal. Most of the time they're menopausal at that point.
And for the 1/3 of women who don't have a uterus and don't get menstrual periods, I do have a podcast episode on how to know you're in menopause if you don't get a period, because a lot of women don't get periods for a variety of reasons. Monica wants to know about cold flashes. We didn't get into the weeds about hot flashes, and they, for a severe hot flash, which your thermostat is basically broken and you're too hot, and then your body tries to get it right again, and then you get the freezing cold, shivering chills. So how a cold flash can be part of a hot flash. But I will also say, Monica, that you might want to think, if that's the only symptom you're having, to get your thyroid checked, because we all assume that these being cold and being hot and everything is all menopause, and there are other things that can happen. Lisa, you want to comment on that as well?
Well, yeah, right. So certainly you don't want to miss other things, including thyroid dysfunction, and there's other hormone producing tumors that we worry about, and there's other illnesses, lymphoma being something that we look for. So again, not all hot flashes are related to menopause, and it really requires taking a good history and teasing out whether or not this is very typical related to perimenopause and menopause or something else.
Nancy wants to know, and other people as well, about how long can you take hormone therapy? And some doctors say, okay, it's 5 years, you have to go off. That's not based on any scientific evidence. There's no medical reason to do so. And in fact, in our menopause center here at Northwestern, we do not take anyone off their hormone therapy ever, unless they either desire to do so for some reason or they have a medical reason to do so. And this is something that at the last NAMS meeting that Lisa and I both attended, there was a lot of discussion about, is there any scientific basis for women to stop their hormone therapy? And the answer is no. And the benefits beyond hot flashes, of course, in terms of bone health and sexuality and all of that. But it is a little bit controversial. You want to talk about the flip side of that?
I mean, so certainly the 2022 NAMS position statement on hormone therapy, right, has taken out any language about duration of use. And that's right. It's very individualized, right? So if a woman has bad hot flashes, starts hormone therapy at age 50, is doing well on hormone therapy, I do not have an automatic stop date, just as Lauren said, at all. What we do is very carefully, as a woman ages, think about her ongoing risk of developing other diseases, right? So we continue to look at what's your breast cancer risk, and we think about what hormone regimen you're on, but then it's really assessing cardiovascular risk and thinking about that, right? So what we worry about is, as women age, certainly cardiovascular disease and stroke risk. And what we know is that there's different formulations of estrogen that are better to use if you're worried about those kind of things, specifically patch or gel hormones. The safety of transdermal estrogens compared to oral estrogens is well established. And so as women age, I would tell you my approach is, again, I'm always thinking about cardiovascular risk, stroke risk, diabetes risk, breast cancer risk. We're talking about what type of estrogen you're on, and then often making sure they're on transdermal, and I will often gradually lower the dose. I can tell you that in women over the age of 70, and I do have some women over the age of 70 still on hormones, that's when I'm starting to have them on very low dose or trying to think about getting them off, only because as the internist, that's when I start to see increased stroke risk. Again, it's not.
But if they're on transdermal, Dr. Larkin, we do not see that increased risk with transdermal, correct?
And again, this is part of, I do coronary calcium scoring, to refine cardiovascular risk. There's ways that this is a very individual discussion with each patient. And again, it goes back to, it's not black or white. And if your provider isn't comfortable talking about the nuances of hormone therapy, then you should get a consultation or find a physician that does.
Okay, migraines with aura starting at age 50, still getting hot flashes. A neurologist says estrogen, no way. So other options, I mean, I think any of the other non-hormonal options we talked about, and I do want to mention my other book, Hot Flash Hell, but I have a chapter on every single non-hormonal option. But Lisa, you're the migraine specialist. Do you want to comment on that real quick?
All right. So no, I would quickly say, so right, migraine with aura in general, in a 50-year-old, we are concerned about hormones if they have classic aura. Now, one of the things I will tell you is that many women, their migraines get better after menopause, right? It's the perimenopause, when hormones are all over the place, that women are most often having a lot of trouble. But just like there's exciting science in the hot flash space, in the last couple of years, the science in the migraine space has just been incredible in terms of really understanding the pathway and what triggers a migraine and the pain, which is, again, led to very specific directed therapies. And these new medications called the CGRP drugs, both for prevention and for treatment of acute migraines, have been a game changer in my practice for many, many, many women. And that is a non-hormonal option and something absolutely you should talk to your physician about.
All right, I'm going to do one more that I'm actually putting three together in this one. And basically, this is about the side effect of estrogen. People are mentioning about swelling. One person's swelling in their ear. Someone's also talking about bloating elsewise. What I would say is, number one is sometimes it's more the progesterone that someone is taking with it rather than the estrogen. So certainly look to that. And as someone asks about what about progesterone, we haven't talked about that, but women who have a uterus do need to take progesterone to protect the lining of the uterus. That's very important. But we do find that sometimes it's the progesterone more than the estrogen itself that's causing some of these kind of like little quirky side effects, if you will. I think, God, I'm sorry we did not get to every single question. I wish we could have. And I guess we'll have to do this again, right?
Yeah.
But
I mean, I just wanted to, one of the things we're going to close this up now. In our survey at the end, which we really ask everyone to stay on and respond to, the last question actually has like, do you want to learn more about sexual desire and orgasm and libido, breast cancer, hot flashes? Mark those up, because we may all be meeting back here again at another point to delve even deeper into these topics. And in the chat also, we put some amazing resources, including those that both these doctors have put out on those issues. So please stay on for the survey. I just wanted to thank Dr. Larkin and Dr. Streicher. I mean, your information is just your knowledge and information is unparalleled. And I think I speak for everyone when I say we could have stayed on all day asking you questions. Well, just one quick thing, Dr. Larkin is able to practice telemedicine in, I think, 12 states now. So you can look at that and possibly reach out to her. This talk is part of our monthly menopause talks for Let's Talk Menopause. Our next one is going to be December 13th, and we will send out information on that. Please complete the survey that we just put up. As always, spread the word, check out our website of Let's Talk Menopause, and thank you both again for providing information.
Thank you.